Hi, everybody. Good morning, good evening, good afternoon. Wherever you are, a very warm welcome to all of you to this post-ASH webinar dedicated to lymphoma and CLL, brought to you by the International Academy for Clinical Hematology. I'm Mohamad Mohty from the Sorbonne University and Saint-Antoine Hospital in Paris, in France. And it is my great pleasure to moderate this post-ASH webinar with top expert colleagues, namely Dr. Clementine Sarkozy from France, Dr. Remy Dulery from France, Dr. Bazarbachi from Lebanon, Dr. Arnon from the Netherlands, and Dr. Nitin Jain and Ghosh Nilanjan from the US. And as you may guess, the ASH meeting has been quite an amazing one, actually. And we already did post-ASH roundtable discussions related to myeloma, to transplant, to MPN, acute leukemia. And today we're closing actually this series with lymphoma and CLL. So thank you for joining us. Please bear in mind that this is an interactive activity, so please don't hesitate to share your questions and comments with the faculty, and I'll do my best to distribute these questions. So let me start just to kick off the discussion, and we'll start by alphabetical order. So we'll start with CLL. And my question is straightforward. If you have to get one take-home message from ASH 2023, what is your take-home message from ASH? And I don't know who wants to start. How should we do it? I can see. Should we take it by alphabetical order? First name, Arnon, Cater.
Yeah, thank you, Mohammed, for the question. Yeah, so I think there was a lot of emphasis, and therefore I think it was also only by that already a highlight that there was so much attention of combining two targeted agents that we have known now for a couple of years, a BCL2 inhibitor and a BTK inhibitor with all different kind of flavors, with different durations, but it really, I felt that it really matured all the data, and I think we can debate a lot about it, but the fact that you actually can combine these agents and which lead to very meaningful responses, however you do it, I think that was like for me, an overall highlight.
Superb. Nitin, do you agree?
Yeah, no, I agree. I think, over the years, we have seen ibrutinib plus venetoclax, or for that matter, other BTK inhibitors, covalent BTK inhibitors and venetoclax combinations. And I think specifically we want to ask about one particular abstract. I would say the randomized study from the FLAIR trial, which was presented by Dr. Peter Hillman, I think, and subsequently published in New England Journal as well. I think that trial, to me, was most important from the field about the combination. It was a combination randomized to FCR versus ibrutinib plus venetoclax, and really one of the first trial which showed not just a PFS and an OS advantage of a target therapy, namely ibrutinib plus venetoclax versus FCR, which you could argue, FCR certainly we have moved away from over the years, from different other data sets. But I think we now have a very large, robust data set for dual oral combination therapy, which I think adds to the data we have for the field, and also provided some really nice, interesting observations. And certainly I think we'll discuss that as we kind of go along.
Wonderful. So I can sense here a few keywords when it comes to CLL. So let's engage in the discussion. And let me start first by asking the other members of the panel, what is your standard of care for CLL today in your center, and what would be the future? I don't know, Clementine, would you like to start? Ladies first.
Sure. So in our center, and I guess also elsewhere, we look at the TP53 mutation and we look at the IGVH status to guide our standard of care. And we also look if it's a CLL or lymphocytic lymphoma with a more nodal form. And if TP53 mutated, then we want to have a continuous treatment, maybe more with BTK inhibitors or ibrutinib. But if unmutated and no bad prognosis factors as no with a mutated IGVH status, then we like a short treatment with BCL2 inhibitors and the anti-CD20 of choice that would be obinutuzumab. And in the future, well, we wait for the long-term follow-up of the combo, of course, and looking forward to use this combo.
Ali, what is your standard of care?
Good evening, everybody. I'm Ali Bazarbachi from the American University of Beirut in Lebanon. So our standard of care is somehow quite similar to what Clementine proposed for patients with mutated IGHV without TP53 mutation. These patients are exquisitely sensitive to anti-CD20 monoclonals, particularly obinutuzumab. So our preferred regimen is a 12 months and probably in the future a little bit less of obinutuzumab and venetoclax. For patients with unmutated IGHV in the absence of TP53 mutation, we're going with the combo of ibrutinib, venetoclax. However, we stick to a longer duration of combination treatment of 24 months as per the MD Anderson study rather than the 12 months of the Captivate and GLOW study. And for patients with mutated TP53, we tend to go with continuous BTK inhibition, even though there are encouraging data with a 24 months combination of ibrutinib and venetoclax, but still we don't dare stopping treatment in TP53 mutated.
So should I understand, and Ghosh, maybe you can handle this, that FCR is about to retire or is already retired as a regimen?
Yes, I totally agree. At our place, I don't think we've done FCR on any patient in the last 4 years or so, perhaps even more, 4 or 5 years. And we have really swayed completely away from chemoimmunotherapy in CLL now for a while, with the occasional patient who is completely unreliable in terms of taking oral medications or has compliance issues. And maybe for that situation, a rare BR or I know brentuximab based regimen, but in general, outside of those kind of situations, we've not used chemoimmunotherapy for a long time now.
Remy, is there a word in defense of FCR, limited duration? Because we'll speak about fixed duration versus continuous. And there are patients who received FCR and they are in remission over the long term, even maybe cured. Any thoughts on this?
Yeah, I think you're making a very good point, Mohamad. Like in most centers, we rarely treat patients with FCR, but I still think there are small subset of patients who can still benefit from it. It's patients who have no abnormality of TP53, or a young patient with no unfavorable genetic abnormalities. And it's true that those patients may benefit from a short duration of treatment with 6 cycles of FCR. And when you look at the results, I think so far we have not shown that we can have a better overall survival for those patients with chemo-free approach. So maybe it can also be based on the choice of the patient, what he will want, but it can be appealing for some patient to be treated only for 6 months compared to longer duration of treatments with ibrutinib or acalabrutinib.
Thank you. So let me circle back to you, Arnon, and this issue of fixed duration versus continuous treatment and maybe MRD-guided therapy. And this is, I think, one of the issues debated during the ASH meeting. What is the current status of assessing MRD and using it to guide therapy? Are we ready for prime time?
So before I answer that question, I need to confess that in the Netherlands, actually, maybe we're one of the last places where FCR is still considered standard treatment for specifically for the mutated patients. And although I am more, I think, on the side of the people that think novel therapies might be easier to handle and maybe better for toxicity, the reason that there is a merit for it is specifically if you look to the overall survival of mutated patients. And very recently, we had a very nice, very long-term follow-up paper of Philip Thompson from the MD Anderson group, which actually showed indeed that you start to see a flat line in like 30 to 40% of patients with mutated IGVH after FCR. And since, of course, we need to wait for the other data to mature there, but there is really a merit for FCR still, and that longer-term follow-up we still don't have. So just for that comment, I think there is, but you can also, of course, argue the other way around with late toxicities like a treatment-related MDS AML, specifically in the elderly FCR patients. But that's what I want to say about that point. About MRD, well, it's very nice to have a debate with the team here, because I'm also a bit confused what to do now after seeing the flare data. To me, but just as an opening remark, and let's see how the rest responds to that. What I think, if you combine the glow, the captivate, and the flare, you mix them all and you see what comes out of it. I think the picture is that for mutated patients, although most of them are MRD positive, also at fixed duration, venetoclax and ibrutinib, the PFS remains very high, at least at this time, so like above 90 or around 90%. While for unmutated patients, if they are MRD positive, you really seem to have a shorter PFS, and maybe those patients need to be prolonged. So I think it's still debatable, and the question is, I think it's still too early to do it in clinic to adopt a whole flare-based regimen. But I would like my fellow debaters here to ask if they agree that, if anything, maybe mutated patients, it doesn't really matter if you give 15 cycles or 25 or more, but for the unmutated, there seems to be more of a gain with continuous treatment.
So just to clarify for our audience, because it may be obvious to all of us, the FLAIR trial, this is ibrutinib and rituximab versus fludarabine, cyclophosphamide, and rituximab for frontline treatment of CLL.
No, it was venetoclax and ibrutinib, actually. Ibrutinib and venetoclax.
Okay.
Yeah, so the FLAIR, as I shortly, so the FLAIR is a phase 3 trial where from the UK group, where all the time the standard arm is FCR already for the last couple of years, and every time the study treatment changes. So this time it was a readout of venetoclax and ibrutinib, and they have this interesting way of giving MRD base. So what they do is they determine the time it takes from start of treatment till MRD negativity, and that time is doubled after MRD negativity for another period of time, and then they stop the treatment. So if it takes you 12 months to become negative, you get another 12 months, a total of 24 cycles. If it takes longer, you just double that. That's what they did. And there they showed very good PFS and OS data.
And Captivate, this is a fixed duration ibrutinib plus venetoclax.
Yeah, exactly. Both same regimen, ibrutinib, venetoclax, but then very simple, so not too difficult for the clinic. 3 months of lead-in with a BTK inhibitor, in this case ibrutinib, and then 12 cycles of combination BCL2 plus a BTK inhibitor.
Excellent. So Nitin, what is your take on this?
Sure. Yeah. I think the FLAIR data, which we're discussing, I think, it adds a new strategy, right? Previously, I think all the trials, if you look at, again, ibrutinib plus venetoclax combination trials, whether it's MD Anderson study or the Captivate study or the GLOW study, all used time-based duration. GLOW and CAPTIVATE were 1 year of combination. MDN study, when we designed the study some years ago, we just picked 2 years of combination actually for frontline patients. And, but then the flare comes about where they, as, Arnon said, they used this MRD-based approach. And MRD, I should say, is 10 to the power minus 4 sensitivity, where you double the duration of time it takes to get MRD. So 1 year to MRD negativity at 10 to the power minus 4, you get 2 years of therapy. And then if you get 2 years, so it takes 2 years, you get 4 years. If you take 3 years, you get 6 years. So really a lot more treatment per se. In fact, if you look at the trial, about half of the patients stopped after 2 years of therapy, but then the remaining half were continuing therapy beyond 2 years, 3, 4, 5, and 6 years. So basically you're getting much more depth of therapy or duration of therapy. And then the PFS curves, if you look at, 3-year PFS was, upwards of 95%, and which is obviously very, very fantastic. And if you look at our MD Anderson PFS, we also reported a 5-year update in a poster session. Our 5-year PFS for MD Anderson cohort is about 90%. But then if you start looking at the CAPTIVATE and the GLOW, which used 1 year of therapy, the 4 or 5 year PFS is on the lower side, at least numerically, So I guess one get a sense, and I guess this was my impression from the data, would be that the depth, the duration, basically, of the therapy is matters, which may be not a total surprise. If you give more therapy, maybe you will get better outcomes. I guess the question will remain, what is the optimal duration, right? Whether should everyone get 2 years of therapy, or everyone should just follow the flare strategy. But I do think that maybe these two trials, the flare study specifically, and maybe Anderson study to a certain extent, bring this thing out that maybe 1 year, which obviously is the approved regimen of I plus V, may not be sufficient, and maybe the longer duration may be beneficial. So I think I think to me, this was the new kind of a thing which specifically came out with the flare data.
Thank you. Ghosh, what are your thoughts on this issue of fixed duration, and what would be your optimal combination?
Yeah, so unfortunately, we're not able to use, combination ibrutinib venetoclax because it's not really approved in the US in a commercial setting. We have been using that on the, going back to your first question, like what do we use as a standard for our newly diagnosed patients, in addition to doing, FISH and IGHV. We evaluate them for the MAGIC study, which is looking at acalabrutinib venetoclax versus, versus obinutuzumab venetoclax in the frontline setting. So, there we are able to use the combination which we want to use. Ideally, I totally agree with Dr. Jain. I think there is good evidence now that with a longer duration of therapy with a combination, we are seeing a better depth of response. So I think that may be the main take-home message, which is there. But perhaps we could also do an MRD-guided, this thing. So one, of course, the flare, but there was another study called the Bowen study, which was done at Memorial Sloan Kettering and a few other places. It's been now being replicated even in mantle cell lymphoma. But again, there is MRD-guided stopping rules. I think MRD is not being used, at least in the US, outside of clinical trials or outside of certain academic places for routine use, because there isn't very good idea of what to do in terms of how do you react to it. Yes, it's good to know, but am I going to stop treatment? Am I going to extend treatment? What am I going to do with this? Versus just checking for it, because MRD in CLL is different from MRD in ALL. And even though it's MRD negative, we still don't know if these patients, if a subpopulation of these patients are going to be cured or not. So I think overall, I like the idea of a longer duration of combination for at least for unmutated patients. Certainly for patients, if we do the combination in patients with 17p deletion, there I'm a little worried about stopping treatment. at least continue the BTKI. And I might say that Captivate actually had, in addition to the fixed duration cohort, they also had an MRD cohort. It never really, I think the focus has always been on the fixed duration cohort, but they had one in the MRD cohort where they looked at MRD and they decided whether you would continue or stop and things like that. But yeah, so those are my first impressions on MRD and durations of treatment.
Thank you, Ghosh. We have a question from the audience about whether we should achieve MRD negativity in all patients with CLL. Obviously, it's never always in all or in zero. Clementine, what are your thoughts?
So I think it was mentioned just earlier by one of the panelists that maybe it might depend on the mutational status of the IGVH, and if the patient is IGVH mutated, then maybe the fact to remain MRD positive doesn't have the same significance that for the one that have the worst prognosis factor, like unmutated IGVH, where they need to reach the MRD negativity.
Excellent. Thank you very much.
I might just add,
yes, please.
Sorry, I might just add, I think it depends on what treatment you are in. So if you're on a venetoclax-based treatment, or if somebody were to use chemoimmunotherapy like FCR, if that is ever being used somewhere, then I think MRD has a lot more significance than if you're doing a single agent BTK, where trying to achieve an MRD is, you could be perhaps disease control for a long time with some evidence of disease still there and still be not progressing. Versus somebody who is on a different treatment, where if you get an MRD negative, then your progression-free survival is likely going to be very high compared to if you're MRD positive. So I think if you're in continuous treatment, it may be also difficult to achieve MRD, but that doesn't mean it's difficult to have disease control. So having that distinction.
Yeah, maybe just adding to that, I think for chemoimmunotherapy, we are very confident that MRD is really a very prognostic, predictive surrogate endpoint for PFS. We also know this is pretty sure that this is true for venetoclax plus an CD20 antibody. And to me, I think for whether or not it is as robust as a predictor as for the combination of a BTK inhibitor with BCL2 inhibitor, I'm not that sure yet. So I think we still need more data to really know if that should be the goal of this combination treatment.
Thank you very much. Before moving to the relapse CLL, I'd like to take a couple of questions which are of importance, I think. One question is from our colleague, Dr. Perola in Albania, and a big hello to all our colleagues from Albania and in Eastern Europe attending this webinar. It's about whether we should treat or not stage A CLL. I guess there was a randomized trial saying that we should not do it, but Ali, what is your approach?
I still believe that we can have a lot of patients that remain off therapy for a long time, even with TP53 mutation. The only difference that we do compared to patient without TP53 mutation is that we do a closer follow-up. So in patient without TP53 mutation, they can, when we know they are stable over the 1 or 2 years, then it can be every 6 months or even more. For patient with TP53 mutation, we keep them coming for clinic follow-up every 3 months. But still, I think if they do not meet criteria for treatment, they don't need treatment.
Excellent. And actually, you anticipated on a question and comment from Dr. Wandru about whether how we should handle those patients with early stage CLL, but with TP53 mutation. Let's move now to the relapse CLL. And if I remember well, there were 2 keywords at ASH regarding relapse CLL, alpine or alpine and brune. And that brings me to the different BTK inhibitors, because it is becoming a more and more crowded space. So maybe Remy, and let's focus on the traditional ones, because there are now covalent and non-covalent, but maybe just, do we really need at the same time to have available ibrutinib, acalabrutinib, zanubrutinib, and at some point pirtobrutinib, and maybe azadraginib?
Oh, it's a good question. I don't think we definitely need all of them at the same time, but right now we are trying to demonstrate which one fits better for particular patients. And I believe we have now more and more data showing that zanubrutinib may improve the outcomes in relapsing patients. So probably with the time, we might not use ibrutinib anymore. It's just that we have the more experience with ibrutinib now, but we still need to innovate, because one is we still have patient relapsing, and the second problem is some toxicities, for instance, cardiac toxicities that which can be reduced with more recent therapies.
Excellent. So there are two directions, and maybe Clementine, you can comment on this. One is related to the emergence of resistance, which one BTK inhibitor can allow maybe to overcome compared to another one. And obviously, this is maybe a naive comment, but also the safety profile, which can be different, especially the cardiovascular one.
Yes, sure. And as you mentioned, the non-covalent BTK inhibitor can, of course, overcome the resistance of mechanism shown with the covalent one, but they will also have their own resistance. And we can see that more and more, the emergence of distinct type of mutation, even though the data of pirtobrutinib in the first line setting might also be very encouraging. And so maybe the safety profile is the most important thing that we can highlight here, and the safety of the most recent BTK inhibitors are very attractive.
Excellent. So Nitin, how do you navigate among the different BTK inhibitors? Is it just you pick one from the bag, or you have some rules?
Well, I mean, I think, so the three BTK, in the frontline setting, we have three BTK inhibitors approved. So, as you know, in the randomized studies, two randomized studies in the relapsed refractory CLL, one was ELEVATE-RR, which compared acala versus ibrutinib, which has been presented now a few times. Also, the ALPINE study you mentioned, which was updated at ASH, which is zanubrutinib versus ibrutinib. So both the studies have shown that the second generation BTK, namely acala and zanu, are superior from toxicity standpoint to versus ibrutinib. And and this data is not new. This is now a couple of years old data. And so I think our practice at our center, and I think many physicians across the country, have really moved away from ibrutinib. And in fact, we are not prescribing ibrutinib for our patients. We're really, practically 100% of patients are getting a second generation BTK inhibitor in the frontline setting. And so, the choice between acala and zanu, I don't think, certainly the efficacy-wise, zanu versus ibrutinib showed PFS advantage of zanubrutinib versus ibrutinib. That was not seen with acalabrutinib versus ibrutinib. But having said that, those are two different trials, so we cannot just say that means that zanu is superior to acalabrutinib. So I think in our practice, we kind of use them interchangeably. Certainly we have slightly more experience at our center with acalabrutinib. It was approved, a few years earlier. But at the same time, I think both are excellent drugs. Eventually, yes. I mean, I think in the relapse setting, we recently also, just around the time of ASH, just before ASH, pirtobrutinib was officially approved by the FDA for CLL. So now we have the agent again also available, but that is slightly unique. I think we call them all BTK inhibitor, but as we were, kind of maybe discussing, pirtobrutinib really works for patients who have failed a covalent BTK inhibitor. So it's a unique mechanism of action. and certainly right now is one of the preferred options when patients have failed, both BTK and a BCL2, so so-called double refractory or double exposed patients.
And it is not yet reimbursed in the States, right? But they have this expedited
No,
program?
so the pirtobrutinib was officially approved by the FDA for CLL, I believe, in December 1. It was approved for mantle cell lymphoma early part of 2023. So now it is officially approved. I can just prescribe it, and it is covered by insurance. So it's available, and we were able to use it even before that when it was approved for mantle cell lymphoma, because it was added to the NCCN guidelines, which are the guidelines in the United States. Yeah, so it's kind of freely available for CLL patients as long as they have had both a BCL2 and a BTK inhibitor.
So Arnon, you said that in the Netherlands you were still have some sympathy or affection to FCR. Is it the same story for different generations of BTK inhibitors?
Yeah, actually, I wanted to make exactly that point. I'm not sure why we are so different in that. It could be that we have a very strong socialized medicine background, and we as medical doctors are also, although things can be labeled and approved, we as a medical group are also partly responsible for the total budget, which is rising every year like crazy. More of our friendly myeloma friends than CLL, but also we are doing a good job there. And to be honest, I have to say that many patients do pretty well on ibrutinib, of course. And if you look to the data where they compare the different BTK inhibitors, so Zana versus ibrutinib or Acala versus ibrutinib, it's indeed, you see more atrial fibrillations for sure. With ibrutinib, you see more hypertension, but it's still a minority of patients. And it's also true that the younger patients, if you compare GLOW to Captivate, so these are the fluctuation treatments again, but if you compare the toxicities, you really see that patients with uncontrolled hypertension, a BTK inhibitor, and maybe specifically ibrutinib is not a good idea. But if you have a no cardiac history, I think it is still a good drug. And the reason that I'm a bit afraid of completely abandon it is what's happened is a bit the same what happened a couple of years ago with CML, that we all very quickly went to second and third generations of drugs, while at the end, when the patent is off and the drugs get very cheap, then I think it's very attractive to not completely abandon these drugs that work, but you have to identify your patients carefully.
So that was exactly the question I wanted to ask, but maybe Ali, you want to add something?
Yes, actually, now I think that we have more and more accumulating data that if a patient develops side effect while on ibrutinib, reducing the dose does not harm in terms of maintaining the response rate. And actually, we have a significant amount of data showing that patients who received reduced dose ibrutinib have exactly the same PFS than patients who receive full dose ibrutinib. So sometimes in the early years, we were afraid of reducing the dose of ibrutinib in case of side effect, thinking that it may lead to decreased efficacy. But apparently, this is not the case, and we can manage a patient that way without necessarily shifting them to second generation in terms of cost containment strategy.
Ghosh, is this common practice to reduce the dose and what Dr. Bazarbachi is claiming?
Sorry, I was on mute. Yes, I actually presented some data with dose-reduced ibrutinib versus full-dose ibrutinib. Now, this is not a randomized study. This is from from claims database, but it's a very large, several thousand patients, and we had some really good ways to study this outside of a randomized trial using some statistically valid methods, and we found that there was no difference in terms of time to next treatment, which was our surrogate because this is not randomized trial for PFS. In terms of time to next treatment between dose-reduced ibrutinib versus those who were on full dose ibrutinib. But I think, and then there is a study called the Taylor study, which has been designed to look specifically at that and actually have a randomized trial. But I think, at least in the US, the world has moved on a little bit to the second generations. One, because Zanu is showing a PFS benefit. Yes, it's not a huge difference, but 65% versus 55% is, I think, what was presented at 3 years from the Alpine study. And then that is one part of the story, but the other part of the story is the better safety profile from a cardiovascular standpoint. I think now we have that 16% number sticks with the AFib rate in ibrutinib, and when you look at zanibrutinib or acalabrutinib, it's in single digits, somewhere between the 5 and 9% range. Yes, these are comparing across trials, but these are large studies, and I don't think an Acala versus Zanu study is ever going to be done. But they're doing some comparisons between these two, and they've not found efficacy differences. So I think with all that information of a possibly better efficacy and a lesser cardiac toxicity, perhaps not others. Hypertension signal may be a little less with Acala. Zanu and ibrutinib both have probably a little hypertension equivalence, but at least AFib is something which people worry about, especially in elderly population and things like that. So if you have a slightly safer drug, which may be more efficacious, you're going to lean towards that. Could you achieve that with a lower dose ibrutinib? Perhaps possible, but I think, people leaning more towards the next generation.
So this is really a fascinating discussion. And it's quite incredible because if we have had this round table, let's say 12 or 15 years ago, actually would have been speaking about chlorambucil, maybe FCR, auto-transplant, allo-transplant. I remember some of the best results in the registry were about allo in high-risk CLL. And it's quite incredible what has been achieved in the last 10 years, where you are able to manage now even high-risk CLL with just a pill a day. And we're debating now about the frequency of side effects and whether we should do fixed duration versus continuous. Thank you so much, guys. Let's move now to lymphoma, and I'll start with Hodgkin lymphoma, because obviously, although it's a relatively rare disease, it has been always a model for cure in oncology. And actually, it's proving more and more difficult to do a right interpretation of the Hodgkin lymphoma trials, because these patients are living very long. And actually, we need to look to overall survival. And obviously, trials are looking to progression-free survival. And obviously, the question may not be necessary about cure, because the majority are cured, but what are the long-term side effects? So, Remy, what has, impressed you in terms of Hodgkin lymphoma at ASH 2023?
Well, there is a lot to unpack, of course, on Hodgkin lymphoma, but I will try to summarize some maybe take-home messages. I think this year at ASH, we mainly had advances on the first line of therapy compared to other ASH, where we had more news about what you do in relapse or refractory disease. And the general idea of ASH this year, I think, is that anti-PD-1 blockade is moving to the first line therapy. And well, it is not approved yet, but we are gathering more and more data showing that patients can benefit from using anti-PD-1 blockade as a first line therapy combined with chemotherapy. So we have studies comparing nivolumab AVD to brentuximab AVD. So this is ABVD without bleomycin. And those studies show a benefit of nivolumab AVD compared to brentuximab AVD in terms of progression-free survival and in terms of safety profile in all categories of age, which includes older patients and younger patients, pediatric cohorts. We also have association of nivolumab with brentuximab, doxorubicin, and dacarbazine as a first-line therapy with very promising results. So overall, for the first line, and we can dig deeper in those studies if you want, but it means we are getting rid of bleomycin. This is very important for the quality of life of the patients, the long-term pulmonary toxicity. We have less cycle of chemotherapy, and we have less radiotherapy. And for refractory disease, for relapsing patients, we are also having the confirmation that we should use anti-PD-1 blockade earlier in the treatment lines. There has been studies showing that the earlier you use anti-PD-1, the better it is for the outcome. And finally, as a hope for the patient, we are developing interesting constructs of NK cell therapies, especially I think the one presented using the anti-CD70 constructs with allo NK cells are, for me, very promising for those patients.
So we'll talk about cellular therapy in a few minutes. Clementine, based on what Remy mentioned, are there a subgroup of patients for whom you are willing to move away from the classical ABVD or BCOP and incorporate the new approaches, whether brentuximab based or whether nivolumab based?
Sure, and you mentioned that for Hodgkin, cure is not, it might be not an issue anymore because we cure a lot of them, and I would say that there is a small portion of the patients where Hodgkin remain an issue. It's the elderly patients, and I think if we look at when no one has the same standard because we can have a lot of toxicity, and also these patients tend to have a worse prognosis factor with a worse PFS. So definitively for this one, I would love to be able to use anti-PD-1 at first line and to get rid of the toxicity of some of the chemo regimens and reduce with AVD at least, yeah. So it's definitely the population where I would start with.
What's the opinion of the CLL colleagues? From outside, looking into this story, I guess let's figure it out, Arnon, from a health economic perspective.
No, I'm also very impressed by the data, and actually I just came from in my outpatient clinic from a 20-year-old girl with stage 4 Hodgkin lymphomas, and I had to tell her about all the toxicities, about the cryopreservation for her future family planning. So indeed, if we have something better with less toxicity, I think that's really great. And there is very much an unmet need specifically for this high risk group. So I'm also very impressed, and I think it would be very good if you could lower the chemotherapy by including those targeted agents here.
But let me try to be the devil advocate. The criticism that is more and more brought into this field is that we need to look into overall survival. We need to show an overall survival advantage. And so far, the follow-up is relatively short, and we don't have this overall survival advantage. So how can we get a sort of a meaningful sense of these data in order to use them in the clinic? Ghosh.
Yeah, so I think that's a great question. So if you go back to the Echelon study, we know that we kept getting PFS, first modified PFS. This is BV-AVD versus ABVD, right? So we know that we had improvement in modified PFS, then we had improvement in traditional PFS, and at 6 years, is when you saw the overall survival improvement. And that is because salvage therapies are so much better. Transplant for patients who get a CR gets you very good outcomes, sometimes up to a 70% cure rate if somebody is PET negative CR in salvage, followed by autologous transplant. So it may take a long time to show an overall survival benefit because the salvage therapies are better. I think SWOG 1826, which was mentioned, Nivo AVD versus BV AVD, is very significant, because one, we talked about the elder patients, and if you look at the older patients, about 100 patients, which is presented by Sarah Rutherford at ASH, the difference is striking in the PFS. You're talking about, a PFS at 1 year, 93% versus 63 or 64% for BV-AVD. So that is a pretty significant difference. Second is the toxicity, because BV-AVD can have significant neuropathy and you need growth factor support throughout, which can have its own toxicity and with every 2-week regimen. When you look at Nivo AVD, especially in the older patients, the toxicity is far less. And so you're talking about a very significant improvement in PFS. Yes, the follow-up is very short and we have not reached medians yet, so maybe a little early, but even from a quality of life perspective, BV-AVD, the neutropenia, and also with the growth factors as well as the neuropathy can be a real problem for the elderly compared to Nivo-AVD. And I think the difference in the elderly is a little bit more striking because perhaps there's a little bit of immune senescence in the elderly, where the immunotherapy is not super as active as in the very young patients, where there may be more toxicities in terms of autoimmune toxicities compared to the older patients. So I think this is a huge advancement, and the field has really moved nicely from chopping away certain drugs from the ABVD regimen, very nicely taken bleomycin first, and then now they're also working through the other regimens, as Dr. Dulery just mentioned, the other BV, Nivo, dacarbazine, the one from MD Anderson, Hunley's presentation, also having very good activity, combining 2 novel agents and then some chemotherapy still. And ultimately, there is already BV, Nivo data as well. So I think there are improvements which are happening in Hodgkin in a different way. I would end by saying that even though overall survival is important, think of the young woman who could get cured with frontline therapy, and the chance of infertility is low, and she would never have to go through a transplant, attain early menopause, worry about all those things. So you want to be able to cure people the most you can with frontline therapy, and hopefully not have to give them salvage therapy, even if it's not an overall survival benefit.
Excellent. So assuming we use these novel therapies or novel combinations, frontline, how do you manage relapse disease? Ali, any thoughts on this?
So it depends what we are using frontline. So if the frontline therapy is BV-AVD, which was actually based on the Echelon study, outperformed ABVD, not only in terms of PFS, but also in terms of overall survival at 6 years for patients relapsing after BV-AVD. I think that the strategy is checkpoint inhibitor-based salvage and autologous transplant. And in that sense, actually, at the last ASH meeting, there was a very nice study by Sanjal Desai from Minnesota about high-dose therapy in patients with relapsed Hodgkin lymphoma using anti-PD-1 containing salvage therapy. And actually, they included in this retrospective analysis around 1,000 patients that they were divided into 3 groups: those that underwent autotransplant after chemotherapy, those after BV, and those after anti-PD-1. And the PFS, the 2-year PFS was 93% after PD-1 compared to 74% after BV salvage and 72 after chemo salvage. So definitely for patients who are relapsing after a frontline therapy containing BV, I believe a strategy of anti-PD-1 and auto-transplant would lead to excellent long-term results. So now, if you ask the question about patients relapsing after a combination of BV and checkpoint inhibitor in the first line, I would say I don't think that you will have a lot of candidates in that setting. So Remy mentioned the study by Abrapsom that was presented at ASH. So this was for early stage Hodgkin lymphoma, and they combined brentuximab vedotin, nivolumab, doxorubicin, and dacarbazine, and 154 patients were included. They received 4 cycles only because it's early stage. The 12 months PFS was 100%. The 18 months PFS was 97%. And there was only 3% of patients with grade 3 peripheral neuropathy, basically because one of the major reasons of peripheral neuropathy in BV-AVD, contrary to BV-CHP and T-cell lymphoma, is that you are combining 2 neurotoxic drugs that are vinblastine and BV in the BV-AVD. So here in this trial, they got rid of vinblastine as well as of bleomycin, and they only had 3% of grade 3 peripheral neuropathy. And one important, I would like to finish just by 2 words about one important study that was presented at this ASH meeting was the German randomized trial comparing BRICAD versus escalated BIACOP. You know that escalated BIACOP as first-line treatment is quite popular in many countries, not in all countries, and it is always a controversy and a debate. But for those who were previously using escalated BIACOP, the HD21 phase 3 study from the German Hodgkin study group presented this randomized phase 3 study where in brentuximab, icatibant, a lot of drugs were removed from escalated BIACOP, and the 3-year PFS overall was 95% for BRICAD. We're talking about advanced stage Hodgkin lymphoma. The majority of patients had a PET2 negative, and therefore they only received 2 additional escalated BIACOP. So two escalated BIACOP, PET2, and then 2 escalated BIACOP or BRICAD. And with 4 cycles of only for these patients, the 3-year PFS with BRICAD was 97.1%, which is quite impressive. So even in advanced stage Hodgkin lymphoma, you can cure a large majority of patients while reducing significantly toxicity and probably long-term side effect also.
Explain a bit, Ali, what's the BRICAD? What is actually, what is it? You give brentuximab plus, what is the other drugs component?
Okay. So basically in the BRICAD, it is brentuximab, etoposide, cyclophosphamide, doxorubicin, dacarbazine, and dexamethasone. So you are removing bleomycin, you are removing vincristine, from, I mean, a lot of drugs that were used in the escalated BIACOP. And you're replacing prednisone with dexamethasone.
So one quick question, because we have to move. We have several diseases yet to analyze, to discuss. Nitin, what is at MD Anderson the frontline therapy for a newly diagnosed Hodgkin lymphoma age 60?
Oh, you're on mute, Nitin.
Sorry, I was not able to unmute myself for a second. So in all fairness, I'm part of the leukemia group, so I myself don't treat Hodgkin's lymphoma patients at MD Anderson. So I'm not entirely sure what clinical trial they have exactly right now, but I would just say in one quick sentence that I think the data with Nivo AVD, I think what I heard from our internal group, I think we're quite excited about seeing this data, which now has been out there for some time, and to move with checkpoint PD-1 in the frontline setting.
Wonderful. So it looks clear that in Hodgkin lymphoma, it's not only about the more than 90% cure rate, but it's also about quality of life and side effects. So it's living long and well. Let's move to mantle cell lymphoma, guys, because again, it's another disease where we have seen amazing and incredible advances in the last 15 years. And actually, we were talking about BTK inhibitors, and this is a disease where BTK inhibitors can play a role. So I don't know who wants to, Clementine, maybe give us a summary about the current status of management of mantle cell lymphoma before and after ASH.
So
very ambitious question.
Challenging, yeah. Challenging question. So the field is moving from a mantle cell lymphoma definitively, and it's moving since even 2022 ASH, where in the first line setting, we tend now to use the triangle data as the standard of care, including so the BTK inhibitors in the first line setting. So of course, this will also have some consequences for the relapse setting. And I think one of the take-home message from this ASH is the Simpatico trial that was reported in the late-breaking session, showing that the combination, as in CLL, of ibrutinib and venetoclax is actually doing really better than ibrutinib alone. So maybe, hopefully, we will have the approval of venetoclax with this study that we currently don't have yet. With regards to the other relapse, we also have some novel BTKI coming on the field with pirtobrutinib in CLL, and the market approval is on the process, and hopefully we'll be able to use it pretty soon. And the data in the BTK naive patients are also very appealing. And I don't talk about CAR-T or bispecific, because the question was more around BTKI.
Absolutely. Is there still a room for auto transplant in mantle cell, Remy?
I think now less and less autologous transplant because as we have very good results now with the first line, but also we have very interesting results with the use of CAR T-cell therapy, which confirmed this year at ASH. So I think we're going to have less and less patients in the benefits of high-dose chemotherapy followed by autologous transplants. More and more patients will benefit from BTK inhibitors and venetoclax as maybe first or second line. And then you can move to CAR-T. And then after that will be allogenic transplants. So I think the indication of autologous is very limited now.
Ghosh, is it the same feeling on the other side of the Atlantic?
Yeah, so we are doing autologous transplant on a clinical trial, where basically patients who get a MRD negative CR, they get randomized to autologous transplant followed by rituximab maintenance versus no autologous transplant. It's a big cooperative group study. And if you're MRD, so the question was, if you are able to get MRD negativity just with chemoimmunotherapy, do you really need an autologous transplant? This trial was designed before the triangle data came out. So, we'll have to see what the results are going to be, but the trial is nearing accrual, and a lot of our patients who are actually sent to us for transplant, they are, going on this study. I would say that there is not a very clear consensus here as to whether patients should go into autologous transplant or not. Incorporating ibrutinib in frontline mantle cell has also not become standard. So the data is all over the place. I think still a fair amount of transplants are happening for mantle cell lymphoma here.
Any other key messages from mantle cell? Ali, you wanted to?
So actually, I somehow disagree about the lack of use of autotransplant, at least in frontline therapy for mantle cell lymphoma. Basically, in the triangle study, the control arm was a suboptimal arm that did not include any type of maintenance in about half of the patients, whereas in the experimental arm, 100% of the patient had maintenance. And therefore, if we compare in modern days, autotransplant, if you take, for example, the Lima 101 trial, with high-dose cytarabine, and obinutuzumab and autotransplant, then maintenance and MRD-directed maintenance, you are at more than 90% PFS with a nice plateau, and even from the previous Lima trial with maintenance therapy, you have the majority of the patients that are disease-free at 10 years. So I think that if this is not cured, we can call it functional cure or whatever we want, but we are able to cure patients with mantle cell lymphoma or have treatment-free long-term disease control rather than continuously using a BTK inhibitor if this is not required and not needed.
Ghosh?
I just want to highlight, I don't know if you're moving out from mantle cell, but I wanted to highlight a study which is difficult to do, but I'm glad it's being done, is for P53 mutated mantle cell lymphomas, frontline. So I think, this is a difficult population. We've known forever chemoimmunotherapy, transplant, the outcomes are not good. We know this from registry data and Nordic studies, lots of different studies. But, there was a study which was presented at IACH from, by Anita Kumar, and it was a collaborative effort, I think, between two big centers in the US, where they looked at, it's a small number of patients, but, they looked at the combination of, anti-CD20 antibody, obinutuzumab with venetoclax, as well as zanubrutinib, the Boven regimen, which has been used in CLL as well. And in this group, typically at 2 years, even the overall survival is not good. The PFS is usually less than a year many times. But here, with this novel combination, they saw really, a very high, the 1-year PFS was in the 80s, and the overall survival was, close to 100% at 1 year. And then I think at 2 years, the PFS dropped to something like 70-some%. So I think even though the follow-up is not that long and the numbers are small, I think they're going to double the accrual. This is an important advancement because we know for P53 mutated patients. We don't, and deletion, like, we know that like chemoimmunotherapy doesn't really work that well in mantle cell lymphoma. So I think that's one big advancement. The second one is probably a combination of, mosunetuzumab plus polatuzumab. Even though small numbers, bispecific antibody combined with a ADC in just like 20 patient study, but you're seeing in relapse refractory setting like a CR rate of 70% there. So again, longer follow-up is needed, but bispecifics are making their way, novel agents are making their way. Pirtobrutinib is rescuing patients who are refractory to the covalent BTKIs. So I think even Pirto data was pretty good, about 40%, overall response rate for those who progressed on traditional BTKI. So it gives you another option. So I think the field is moving, in that direction. So I think, it's promising, and the late breaking, which I think was mentioned, of IV versus I placebo, which showed improvement in PFS.
So the last word about mantle cell would be to Clementine.
Yeah, just to comment for the triangle, I think that the results were so pre-planned to doing the rituximab maintenance, and the patient that did not receive rituximab maintenance, and the superiority of the I arm was confirmed also for the patient that received rituximab maintenance, and half of them received rituximab maintenance. But I fully agree that we need to wait for longer follow-up, and I fully agree because we reported them that the Lima 101 results are pretty incredible with the 85% of PFS at 5 years. Even though obinutuzumab is not approved for mantle cell, unfortunately, and we cannot use it so easily. Finally, I love Boven study, and I think Anita's work is really great. I'm just a little bit worried about the Ki-67 curves showing a drop for the patient that have a high Ki-67 greater than 50%, showing that maybe it might not be the solution for the very high risk patient, TP53 mutated and with a high proliferative index.
Superb, thank you very much. So in the last 10 or 15 minutes or so, let's discuss, we won't be able to go into DLBCL, follicular, marginal zone, but I think one keyword, or maybe sort of an umbrella for all of this, is about immune therapy. And this is about bispecific antibodies, antibody-drug conjugates, but also CAR T cells. We heard about NK CARs, and the Don Thomas lecture by the super Katie Rizvani really was very impactful and was quite incredible. So what are, let me word this question differently. How would we position the role of, for instance, bispecific antibodies today in DLBCL? For instance, is it for frontline? Is it for relapse? How's the field moving? Who want to give us?
I'm happy to take that. So we know already from relapse refractory setting, the single agent bispecific antibodies, especially epcoritamab as well as glofitamab, have very good activity, both just in patients who have not seen CAR T cell therapy and also for patients who have relapsed after CAR T cell therapy or refractory to CAR T cell therapy. And, both these two studies showed that, the CR rate was 39%, surprisingly, same CR rate. Yes, there is CRS and there is some ICANS and things like that. But we learned that, and like any other treatment, we would like to take patients who have take an agent which has such good activity in relapse setting to frontline. So I think, there have been so many now studies taking that approach of either combination in relapsed or moving these antibodies to frontline. And so we saw this time at ASH data from Glofit R-CHOP, whether it was, for high-risk population of those patients who had still ctDNA, they did not meet what would be considered as a typical decrease in ctDNA after 2 cycles, and then so select a high-risk population and then go to Glofit R-CHOP versus just Glofit R-CHOP for everybody. Then we also saw epcoritamab in combination, in fact, with mini R-CHOP. And so, these are, and then there is also Glofit polar CHP, which has been studied. So frontline bispecifics have already been conducted and early results are coming out. The results are pretty good, but they are not comparative, so they are not randomized studies yet, which are being reported. But response rates in the 90s, CR rates in the 80s. So that's pretty good for phase 2s. And then we also saw in frontline that there are patients who are getting elderly patients who there was a report of mosunetuzumab single agent at the previous ASH, and at this ASH, it was mosun plus pola, about 100 patients who got mosun plus pola, and they were candidates who were not, perhaps eligible for anthracycline-based chemotherapy. And so you have some now data with that. The CR rate is about 45%. So I think it could be better. We are not sure whether these patients could have got R-miniCHOP and got the similar results, but now you're trying to get more of targeted agents in this population. But again, a bispecific frontline approach. And then in relapse setting, there is also other things which are coming in. For example, EPCO plus LEN and mosun pola had a lot of buzz. Mosunetuzumab plus polatuzumab in the relapse refractory DLBCL, very, very active agent. We know mosun alone doesn't do much in DLBCL, unlike EPCO and glofitamab. But when you combine mosunetuzumab with polatuzumab, you're seeing high CR rates, more durable responses, and again, sort of free of traditional, cytotoxic chemotherapy. So I think the field is bispecifics, I would say, was the buzzword for lymphoma at ASH. And every line you could think of and combinations, it really made its place. I think there was one which I thought was very unique. This is a French study. It's a European study, but it's called the BICAR study. And this is very interesting because one of the problems with bispecifics is the long time it takes to ramp up. And
but it is a made in France. Let's call it like
it's made in France study.
It's a French study, fully French.
Okay, I said French, but then I couldn't remember exactly. So, but I really like that study because one of the big hurdles with bispecific antibodies is the time it takes to get to the full dose, and I understand that's because of CRS. But the best part of that study is that they took that time period and shrunk it down, and day -3 start obinutuzumab, and then after that day 1, 3, 8. And by 15, you're already at full dose glofitamab, and did not see increased CRS. So I think that was a very good way for the world to know that, because for the relapsing patient, you don't want to wait for 1 month till they get the full dose. And they're not going to help. Obinutuzumab alone is not going to do much. So this I think was a very, very good, innovative approach. And I think it'll teach us a lot, and it'll be applied in many other ways so that we can make this ramp up quicker.
So, okay, let's address one last question, which I believe has created some debate at the last ASH. I think people were until recently quite convinced about the role of CAR T cells and their superiority compared to auto transplant, thanks to the randomized trial. But then we had this, registry-based study showing that maybe in some patients who can be salvaged actually with conventional chemo and achieve complete remission, actually high-dose chemo can be useful. And this is a little bit challenging, the role of CAR T cell, extracting a sort of a subgroup of patients who actually can still benefit of auto. Who would like to comment on this, and then we'll close the debate? Ali.
So thank you, Mohamad. I think that this is a very important question because actually I believe that the randomized trials have mixed somehow apples and oranges, mixing primary refractory patients. I would say those who did not achieve CR with chemoimmunotherapy frontline, or those who relapse within 6 months, versus patients who achieved CR and then had a relapse, let's say at 9 months, 10 months, less than 12, but and these patients sometimes due to logistical issues, they receive bridging chemotherapy before CAR T, even if CAR T, and some of them achieve PR or CR. And in a previous blood publication, recent blood publication by the CIBMTR, they showed, I would say, equivalence between CAR T cell and auto transplant for patients who achieve PR with salvage therapy. But at the last ASH meeting, they showed a significant superiority of auto transplant over CAR T for patients who achieve CR on salvage therapy before with a 2-year PFS, 66 versus 47%, relapse rate 27 with auto transplant, 48% relapse with CAR T at 2 year for CR patient, and overall survival was superior with auto transplant, 79% versus 65%, and this superiority was even for early relapse less than 12 months. So regardless of the time of relapse, even for patients who achieved early relapse less than 12 months, they had with auto transplant 68% PFS compared to 48% with CAR T, and relapse 25 versus 46. So this was confirmed, of course, in multivariate analysis for relapse progression and for PFS. So I believe that if tomorrow you have a patient who relapse at 10 months and for whom who was referred to you to do CAR T or transplant by a center who treated this patient with 2 cycles of RD-HAP or whatever, and the patient achieved complete remission. These data, I mean, I would say that auto transplant in that setting is not only a viable option, but maybe I would like to be cautious, a preferred option.
Remy, a quick comment.
No, yeah, I mean, it's just very clear. I totally agree with what you said, Ali. I just wanted to highlight, because I know we're running out of time, just two, I think, very key messages in the field. Is that first, I think we have the very important information about the sequencing of bispecific and CAR T cell, and it has been highlighted by a presentation by Gloria Jacoboni showing the use of CAR T cell after bispecific. And as opposed to multiple myeloma, we can see that it's still efficient to use CAR T cell after bispecific. And the second message is that there is no correlation when you have toxicity with bispecific. It doesn't mean you will have CRS with CAR T cell. So I think it was very important information, because bispecific therapy are moving toward the first line. And it's important to know we can still use CAR T cell. And just very quickly, just one sentence, because it's really moving also the field, is the use of ctDNA. We had a lot of very interesting abstracts hinted that it's not in routine practice now, but it offers the possibility to characterize tumor from blood. And I think it will help to guide the sequence of treatment, because it can potentially predict the relapse and progression-free survival of patients, and maybe help in knowing what you do if a patient is undergoing CAR T cell. You look at the ctDNA, and it can guide you on what will be maybe the next therapy of the treatment.
Arnon?
Yeah, very quickly. Yeah, just since we started about CLL, maybe we should also end with CLL, but then in relation to T-cell therapy. So very shortly, with all the enthusiasm that we have for targeted agents, we also know in CLL that they are not curative, and actually the patients with targeted therapy refractory CLL is actually accumulating. I think what was very interesting and maybe also a bit disappointing that we saw data this ASH about I think the most mature CAR T cell data we have seen, which gives a CR rate of about 18%. And I think there is a lot still to gain and to learn from what happens in T cells in CLL, either because of the treatment or because of the disease itself. And I think by studying that, we can learn actually a lot also for other diseases where not yet successfully T cell therapy has been applied.
Wonderful. I think we are running out of time. It has been a lovely discussion, guys. I'm really very grateful for your time and for sharing your knowledge in this rapidly moving field. We've seen CLL, mantle cell, now all the immune therapies. I do apologize for the colleagues who posted questions and we couldn't handle them, but I'm sure you can reach out to the speakers. So thank you all for being today on the panel. Thanks to our audience. I think they did very well. They have been working non-stop now for almost 80 minutes. So this webinar is actually concluding our post-ASH series. It has been an incredible time since Tuesday, immediately afternoon after ASH. And now we had several webinars, but the IACH activities continue across the hematology field. And tomorrow, I think, we have a journal club addressing a recently published JCO paper. But in the meantime, I wish you all to stay safe and keep well wherever you are. Take care.
Good evening.
Thank you. Good evening.
Good
Bye.
evening, and thank you very
Bye.
much.
Thank you.
Bye.
Bye.